Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. You're probably wondering what this image is here. Some of you already know what it is. It's a cervix, right? Does it look normal or abnormal? Looks pretty normal, right? Especially after being sprayed with acetic acid, right? Because if it was abnormal, we'd expect to see some sort of strange discolored white lesion, right? But it looks fairly normal. We're going to be discussing this and much more on this presentation of cervix pathology. This is covered in your book, Medical School Pathology and Step 1 Review. You can scan the QR code with your phone or whatever to get to the updated material. So, cervix pathology. Now, the cervix refers to the uterus neck, right? You know that. And you also know that the cervix is prone to cancers, and that's why we do cervical cancer screening, as done in this picture to the right here. The cervix is comprised of the ectocervix, the endocervix, and the transition zone. If you take a look at the image to the right here, does this look normal or abnormal? It's been sprayed with acetic acid and it's showing this discolored whitish grayish lesion, right? This is cervical intraepithelial neoplasia. We know that because we got a biopsy of this at a later date, right? Because that diagnosis is made via microscopy. Non-keratinizing squamous epithelium, as we know, is what lines the ectocervix. And columnar cells make up the inner layer lining the endocervix. The transition zone is the area where the exocervix or ectocervix and the endocervix meet. Now, human papillomavirus is a virus that may infect the cervix and promote the development of cancer. Human papillomavirus, by the way, is a DNA virus. And spread of HPV is by physical contact and sex. Acute inflammation typically eliminates infection, and chronic infection increases the chance of cervical dysplasia, i.e. cervical intraepithelial neoplasia. And the particular HPV types that you must know that are high risk include 16, 18, 31, 33, 35, right? 16, 18, 31, 33, 35. You got it? Definitely must know that. And speaking of which, low risk human papillomaviruses include 6 and 11. Kind of like 7 and 11, but it's 6 and 11. It's a convenience store knockoff. And as you know, there are certain proteins that are important for the process of HPV infection, right? E6 and E7 proteins. And those are produced by the high-risk human papillomavirus types. E6 enhances the degradation of P53, right? So a lot of clinical vignettes like to ask this question because it ties into molecular. Because as you know, P53 is a tumor suppressor. And if P53 is degraded, you lose the tumor suppressor, right? So when you try to stop the tumor and there's no P53 around, guess what? You keep going. No brakes, you keep rolling, right? E7 enhances the degradation of RB. Now, what's cervical intraepithelial neoplasia? Well, as you can see here, cervical intraepithelial neoplasia risk is increased when certain tumor suppressor proteins are lost. Cervical intraepithelial neoplasia is specifically characterized by certain features, including coilocytic alteration, atypical nuclear morphology, abnormal cellular maturation, and elevated mitotic activity. According to the degree of the changes, right, the epithelial involvement by the immature dysplastic cells, certain grades are established as follows, from best to worst. The less than full thickness of the epithelium is involved, that's cervical intraepithelial neoplasia type 1. If about 1/3 of the epithelium's thickness is involved, that's cervical intraepithelial neoplasia type 2. And if 2/3 of the epithelium's thickness is involved, that's cervical intraepithelial neoplasia type 3. The full thickness of the epithelium is affected by carcinoma in situ. Cervical intraepithelial neoplasia typically develops into invasive squamous cell carcinoma in a somewhat of a stepwise method through the varying phases from Sin 1, Sin 2, Sin 3, and eventually carcinoma in situ. Progress is not always forward, right? It can go backwards, and notably, Sin 1 often regresses. The likelihood that a dysplasia would proceed to cancer and less likelihood that it will revert to normal depends on its grade. As we can see here in the various pictures, we can have a normal cervix, right, in A, and progress to cervical intraepithelial neoplasia, to it being a bit worse, and 2, and then making it all the way to 3 in D, right? So what you're looking at in A is normal, and then the various cervical intraepithelial neoplasias, type 1, 2, and 3, and B, C, and D, respectively. Now, carcinoma, right, of the cervix. Cervical carcinoma is carcinoma due to the cervical epithelium. As you can see here in this image, cervical carcinoma looks like it's gotten up into the adnexa. Middle-aged women are the most frequently affected by cervical carcinoma. And symptoms of cervical carcinoma include cervical discharge, vaginal bleeding, and postcoital bleeding. Risk factors for cervical carcinoma include the high-risk human papillomaviruses, right? You remember them, right? Because I just told you. 16, 18, 31, 33, 35, right? And speaking of which, what are the low-risk HPV subtypes? 6 and 11, right? Knock off 7, 11, right? Also, risk factors for cervical carcinoma include smoking and immunodeficiency. Squamous cell carcinoma is about 80% of the cases of cervical carcinoma, and adenocarcinoma is about 15% of cervical carcinomas. They are the two most prevalent subtypes of cervical carcinoma. Both have an association with human papillomavirus infections. Advanced tumors frequently enter the bladder through the front uterine wall and obstruct the uterus, or the uterers, In advanced cervical cancer, hydronephrosis with post-renal failure is a common cause of mortality. Here we can see a figure from a large squamous cell carcinoma that has obliterated the cervix and actually invaded the lower uterine segment. And here we have various stains performed on cervical intraepithelial neoplasia as well as cervical carcinoma in the far right column. So the stains utilized from top to bottom are ecadherin, incadherin, and vimentin. Vimentin's just it pretty much stains everything. Pathologists have a joke about vimentin basically being useless. I think the take-home points about this image is that with cervical carcinoma, there is more sporadic and less ecadherin staining. As you know, ecadherin is an anchoring protein or an anchoring molecule that helps keep neighboring cells connected to each other. And as you can imagine, carcinomas are trying to somewhat get away from each other. That's how they lose ecadherin and start moving around in haphazard ways. Now let's talk about some screening, right? We don't want our patients to get cervical carcinoma, so we're going to do what we can to help keep this away and keep this from not happening to them. Detecting dysplasia of the cervical type before it transforms into cancer is the aim of screening. On average, cervical intraepithelial neoplasia progression to carcinoma takes about 10 to 20 years. The gold standard for cervical carcinoma screening is a pap smear. That's very important. I'm going to say it again. The gold standard for cervical carcinoma screening is a pap smear. It's important for us to know those gold standards. Starting at age 21, screening is first done once a year. Using a brush, cells are removed from the transformation zone and examined under a microscope. Dysplastic cells can be high grade, such as that seen with CIN type 3, or low grade, such as that seen with cervical intraepithelial neoplasia type 1. Cells with hyperchromatic, blackish, or very, very, very blue nuclei and high nuclear to cytoplasmic ratios are characteristics of high-grade dysplasia. It is to blame for a considerable decrease in cervical cancer morbidity and mortality, right? Cervical carcinoma went from being the most common to one of the least common types of gynecologic carcinoma in the U.S., thanks to cervical cancer screening. It's truly a remarkable story. Typically, women with aggressive cervical cancer have not had screenings, right? What do we need to do to fix this? Do we need more outreach? Do we need more education? Public service announcements? Following a negative pap smear, a confirmatory colposcopy and biopsy may be necessary. Adenocarcinoma screening with the pap smear is not very effective due to its insufficient sampling of the transformation zone, i.e. the false negative screening. The incidence of adenocarcinoma has not greatly lowered despite pap smear screening. Human papillomavirus infections can be prevented by vaccination. Human papillomavirus types 6, 11, 16, and 18 are covered by the quadrivalent vaccine. Condylomas are protected from by antibodies produced against types 6 and 11, the low-risk types. Types 16 and 18 specific antibodies offer protection from cervical intraepithelial neoplasia as well as cancer. Due to the small number of HPV types that the vaccine can prevent, Pap tests are still required. And that concludes this presentation. I'd like to applaud you on your success. You've completed another very important part of your preparation for your studies. So hats off to you. You're doing a great job. Keep making me proud. If you have any questions, comments, or concerns, let me know. And look out for the next video. Till then, I'll see you later.